Hi, everyone, and thank you for joining us for today's webinar, Harnessing the Power and Science of the Egg. Fortetropin supports muscle gain, protects against age-related sarcopenia, and excess muscle loss with GLP-1 protocols. I'm Marianne Murphy, Vice President here at the Medical Fitness Association. I'd like to take a brief moment to introduce today's presenter. Dr. Chris Meletis is an educator, international author, and lecturer. His mission is changing world's health one person at a time. Dr. Meletis has authored 18 books and over 200 national scientific articles in journals. Dr. Meletis served as Dean of Naturopathic Medicine and Chief Medical Officer for 7 years for the National College of Naturopathic Medicine, now the National University of Natural Medicine. The American Association of Naturopathic Physicians awarded him the 2003 Physician of the Year. He has a deep passion for helping the underprivileged and spearheaded the creation of 16 free national natural medicine healthcare clinics in Portland, Oregon. Now, today's webinar is sponsored by MYOS MD. MYOS MD is an all-natural nutritional supplement specially formulated for adults looking to reduce muscle loss associated with aging and disuse. Now, as always, if you have any questions as we move through today's webinar, please go ahead and type them in the chat or Q&A section of your toolbar, and all questions will be answered in the end in the order they were received. Okay, Dr. Meletis, take it away.
Well, thank you, and thank you everyone for joining us. Thank you, Marianne. And today's topic is, I think, really, really fun. And one of the things which we all know as healthcare providers is we have to translate science into English. So a lot of the little things I'll be sharing, whether it be visual graphics or whatnot, are also intended to be pre-digested morsels, which makes it easier for us to share with our clients and patients. So the skinny fat is something which we're in chat about, sarcopenic obesity. But the question is, there's this big craze, we all know about it, the GLP-1 protocols, which are really working well, but whether it be a bariatric surgery or GLP-1, when people are really losing a lot of weight very quickly, they are going to lose a disproportionate amount of muscle mass, which is our metabolically active tissue, as we know, and that ends up causing a big problem, which we'll discuss and dive into. Fortetropin is a raw fertilized egg extract with lots of patents on it and lots of clinical trials, which we'll discuss. Or discuss the fact that we want to lower myostatin in the vast majority of cases. With aging, myostatin levels rise. With disuse, like injuries, myostatin levels rise. With obesity, myostatin levels rise. We want to normalize myostatin, and Fortetropin has been shown to do that again and again in clinical studies. Anabolic resistance, first, when we hear the word anabolic, we think anabolic steroids. This has nothing to do with anabolic steroids. But as we're getting older, our muscle does not take up amino acids to increase and support protein synthesis. We'll discuss that as well. And myostatin has been shown to help with that. And of course, we love our myokines. And the myokines, sometimes also referred to as exerkines. We'll have a few slides on those. We'll talk about how our muscles are hormone tissues and entities. And we often thought, okay, well, when I graduated in 1992, I said, okay, my muscle can contract, it can relax, really cool. But it's like, no, it actually produces hormones affecting the entirety of our body. So very compelling. And it just validates what we all do in our careers and our lives. We're moving people and their trajectory forward in a very positive fashion. And my disclaimer is two things. I speak very quickly, and I'm also an educator for MYOS MD. So I'm half Greek, half German. My parents met in Portland, Oregon as exchange students. My dad's Greek, my mom was German. Both, sadly enough, have passed away. But the Greek Sphinx, and there's an Egyptian Sphinx too. We all know about that in Giza, the Pyramid of Giza area. But the Greek Sphinx protected the area of Thebes, a city called Thebes with a B. And it says, which creature has one voice, yet becomes 4-footed, 2-footed, and then 3-footed? And that was the riddle so that you could pass by and go to the Thebes. And many of you probably have heard this, but it is humanity. We crawl, we walk, and unfortunately, we end up with a cane, or sometimes we have 6 feet because we have the little roller ones with the little tennis balls. So our goal is, of course, as a group, is to prevent that from happening whenever we can. We see the aging process. We're aging as well. I'm right at the cusp of 60 years of age. I'm just barely off that. And it's like, wow, the population's aging, and we all are seeing that process. But this aging process can be accelerated with rapid weight loss, leading to sarcopenia that causes the whole ripple effect. So that's important to consider. So when we look at obesity, and I've been dealing with this myself, it's like, okay, I want to lose weight, and I have my Fortetropin right next to my MYOS MD, but I don't want to become a sarcopenic obese individual, so the skinny fat, where I lose my muscle mass and as a result have all these other sequelae. I want to reduce my muscle mass or my obesity, but I don't want to lose my muscle mass, my active metabolic tissue with all that mitochondria. And I want to secure my morbidity and mortality risk factors. And once again, this is 2024 peer-reviewed journal article. And I love some of the graphics in the peer-reviewed literature showing, once again, validating what we've been saying all the way along. Let's really do it in a healthy fashion. Unfortunately, if we think of about a GLP-1 protocol, and just outside of my area here in Hillsboro, Oregon, there's a little sandwich sign in a little strip mall. And it says, come get your skinny shot. It's literally a strip mall. There's no healthcare provider, just a boutique little center there. And it's like, wow, okay, so I get my skinny shot and I'm already kind of eating poorly because I'm an overfed, undernourished person like most of the westernized world is. And now I'm going to eat less of that food. So I'm going to get micro and macronutrient deficient. I'm not going to get protein, not eating my fruits and vegetables. You get the idea. It's like, wow. So when we start diminishing the size of our portions, and they were already often devoid in the nutrients we need, we end up with a lot of problems. And we're going to see that more and more over the next few months and years to come. So when we look at sarcopenia, we look at mitochondrial dysfunction, we look at excess weight and adipokines. Adipokines are part of the exerkines, which are the global thing with myokines and cardiokines, which we'll chat about. But we also see the shortening of our telomeres. So the telomeres are that little zipper-like function on your suitcase or your favorite outfit. And it's like, okay, all of a sudden the telomere becomes shorter and shorter, and we're not replicating as well. And we see more and more amyotrophic lateral sclerosis and Parkinson's and Alzheimer's. So there's a sarcopenia brain connection, which I have some really beautiful slides on. And this whole aging, the accelerated aging process with inflammation. So all very interesting, but the reality is at the age of 30, we're start to lose our muscle mass unless we're doing something about it. And by 60, it's a slippery slope. And that's the one that I'm concerned about personally. But also what's interesting, when we were 30 years old, and some of you may still be 30, you actually make about 60 kilograms per day of ATP. 60 kilos per day, about 125, 130 pounds of ATP per day, turn and burn. I'd give a whole nother presentation on that, but it's like, wow. But now our mitochondria, our energetics are diminished. And then of course we start loading on weight and other things happen as well. So in the peer review literature, we see the mitochondrial dysfunction, physical inactivity, and with all the advances of humanity, I can sit here all day with my microphone and talk, but I'm not exercising. In fact, when I don't leave my home, and I've been a doctor for 33 years, so I'm doing presentations, I'm doing articles, I'm finishing my 19th book right now. And it's like, wow, look what I accomplished. I look at my steps per day, like 1,200 steps. Then I go outside and get my rest of my steps because we're very sedentary as a society. And that's one of the things we all see in our practices. But the concept of geriatric syndrome is the sarcopenia. And we see that again and again. And a person might BMI-wise be okay. They might sneak in at the 25 or 30 BMI. But if you actually look at their muscular health, it's not there. So out of the peer review literature 2023, we see things that feed into sarcopenia on the left-hand side. And we see obesity, physical activity, malnourishment, sleeping too much. Welcome to the world of depression. And then we have, of course, things like diabetes, osteoporosis. And obviously, the last thing a person with osteoporosis needs is to have sarcopenia, because then we have less weight-bearing tissues to, of course, help with bone density. We start seeing cognitive changes occurring. We see Parkinson's, all these things. And we also find that when vitamin D is low, another lecture I give, showing that vitamin D is critical for mitochondrial function. And if we are low in vitamin D, we end up with a problem with the inability to actually stir our mitochondria. And we all know that vitamin D is a hormone. So it's just like cholesterol is made into testosterone and DHEA and pregnenolone and progesterone and cortisol. Well, right off that same cholesterol molecule, we make vitamin D. So yes, it's a vitamin, but it has that hormonal effect. And we have VDR receptors, vitamin D receptors throughout the body. And then, of course, a lovely messed up GI tract. I always ask my patients, well, if I go to a swimming pool, they put chlorine in. If I go to a hot tub, they put chlorine in. But we put chlorine in our water. So if I drink chlorinated water and it's good enough to kill E. coli, is it good enough to disturb my friendly bacteria? There's little things that we never really think about until we ponder, like, oh, okay, well, if it can kill the really bad things, could it kill my, what I call powder puffs, lactobacillus, bifidobacter, and whatnot? Then we see with the sarcopenia side of things, when we get sarcopenia and it's really imposed upon a person's life, they have increased short-term and long-term mortality. They also have decreased survivability from various cardiovascular events, strokes, hospitalizations, everything gets messed up. So going in strong and staying strong is such a motivational thing. And there's two types of people that we all deal with, the proactive type and the reactive type. The reactive type, like, sat on the gurney in the ER, in the hospital, and they're saying, am I next? But now they're taking charge, good for them, but we're trying to get them to be the proactive and be less likely to end up that way. And so this little study here, and figure 3 out of the 2023 metabolism journal, just is very, very compelling. But also the osteoporosis side of things, the cognitive changes, all these things, also non-alcoholic fatty liver, dysphasias, depressions, all with sarcopenia. It's like, wow. So what we're doing as a group is actually helping address sarcopenia and helping on all these factors. Kind of a little fluff up for what we do on a daily basis. Like, wow, indeed, healthier, happier people are going to be better contributors to society. So we all know the term, use it or lose it. And welcome to sitting in front of the computer or having to chart or having to, email clients or whatever. We do more sitting than our ancestors did. But then we end up also with injuries. And the more sarcopenia we have, of course, the more likely we are to have an injury. But the moment we have a disuse event in our lives, we have a knee replacement, we have a hip replacement, we strained, broke something, well, then all of a sudden, myostatin rises. So myostatin actually will increase. So myostatin was already increasing with age and sedentary lifestyle. Now myostatin's increasing because of our sedentary disuse syndrome. And that's further leading to more muscle loss, which makes it that much harder to rehabilitate. Well, this is where Fortetropin will come in. And then if we get really sick, we end up with a condition called euthyroid sick syndrome. And it's actually compelling. 75% of hospitalized individuals will end up with this. It's not a thyroid gland problem per se. It's that our body doesn't know what's happened at a subconscious cellular level. And it's like much like being ancestrally, and there's saber-toothed tigers, and like, okay, I'm going to conserve my calories. I'm going into quasi hibernation mode. But the problem is this also occurs with calorie deprivation. So already we're overfed, undernourished society. Now we're cutting our calories down. I have some friends that have done bariatric surgery. They did not ask my opinion. And they are very thin in comparison. But you can see the quality of that mass in front of me is not healthy. And what happens with euthyroid sick syndrome, and when you're working to rehabilitate a person or get a person that has thyroid problems dialed in, what happens is T3 thyroid levels drop. And T3 thyroid is 3 to 5 times stronger than T4. T4 would be levothyroxine. T3 would be the drug Cytomel. And so as a result, we get this dysfunction. So if you have a person, they're not rehabilitating very well, it's like, hey, let's get a thyroid panel on TSH, T4, T3. Like, wow, we've identified what's going on. And also when we get it dialed in, then all of a sudden the work you're doing and the work they're doing gets much more results. And so once again, all these slides will be available, so don't worry about taking notes. And it's just very interesting to see that our body has a survival mechanism. And in this case, it slows us down. So we get injured, we hospitalize, we cut our calories, and our body doesn't know, hey, well, I'm cutting calories. It says, I'm starving. I'm going to save myself. I'm going to, once again, conserve, and often not what we're trying to get accomplished. And so we see that the T3 thyroid, which once again drops with this illness or calorie restriction, T3 thyroid actually goes down to the mitochondrial DNA and tells it to work. And that's interesting because the mitochondria is our blast furnaces. And that's our energy. That's our Energizer Bunny batteries. But now, of course, we have our thyroid, which makes T4 primarily, and then it's converted to T3. Now, all of a sudden, our thyroid itself, the mitochondria aren't being stimulated. And we end up with fatigue and muscle weakness and decreased stamina. And so we see this vicious catch-22 where the mitochondria needs the thyroid needs the mitochondria. And so we can take care of the mitochondria, and I have some protocols I'll share with you, but we have to make sure that they've got some basic testing done, especially if they've been majorly injured or hospitalized. So the other thing is when we are successful, and I have a very morbid concept of you don't want to die dieting. If you look at the word diet, die's in there. And but if you all of a sudden lose a whole lot of muscle mass, well, what's stored in the fat? So today, I walked by the television. I was sharing with Marianne. I don't watch the news, but I saw a PhD researcher found that there's fentanyl and bottlenose dolphins in the Gulf of Mexico. Fentanyl. So once again, eating high on the food chain concept. But now, and they did that through fat tissue biopsies and sampling. So now all of a sudden, if I'm losing a whole lot of weight, am I mobilizing fat-soluble toxins? Yes, I am. And so what about DDT? And you say, well, Chris, DDT is old news. That was banned in 1972. Yet still to this day, we find that people with Alzheimer's disease have 3.8 times higher amount of DDE, the metabolite of DDT, even though it was banned in 72. These are, once again, the whole concept of foreverness of some of these toxins. Same thing with PCBs. And then we get to the forever chemicals, the carbon-fluorine bonds, and which have exceptionally long half-lives. So now all of a sudden I'm mobilizing all this. So now the question is, every day our body has the ability to deal with a certain amount of toxins. But now we have yesteryears and yesterday's toxins on top of today's toxins. And now our thyroid's slower, which is the human metronome, telling how fast everything's going, including our liver function and our kidney function and our bowels. And these toxins are like taking a feather duster and stirring all the dust. So once again, this is where muscle mass comes in and a succinct protocol. And this is where you and I come in, because we're going to actually help save our patients from well-intentioned harm to themselves. So we can do bariatric surgery, GLP-1, that's going to be part of our conversation. Fortetropin, a fertilized raw egg extract with lots of patents and lots of research. The anabolic resistance is going to be part of our conversation, and the impact of skeletal muscle on our well-being. So great, I'm thin, but if I'm thin and I don't have any muscle, I've just increased my morbidity and my mortality. Now you can say, but Chris, if I'm thinner, I have less risk of diabetes, less risk of cardiovascular disease, less risk. Yes, you do. But also by mobilizing all that fat, you also increase your risk of certain cancers, which sadly enough happened to my younger sister. She lost a lot of weight. She had not had periods. She was menopausal. And lets you know how old I am if she's my younger sister and she's already menopausal. And she lost, I don't think, 25, 30 pounds in 2.5 months of going hardcore vegetable only diet, which I counseled her against. And she ended up having 2 periods for 3 months in a row. The 3rd month, she ended up with a very aggressive breast cancer out of nowhere. Coincidence, causation, correlation? Who will ever know? So the concept of we don't want to sabotage our muscle loss. So muscles burn more calories. We know that. And muscle leads to a higher basal metabolic rate, that turn and burn. And muscle also helps with insulin sensitivity. How many diabetics and pre-diabetics do we have in our groups that we're helping? A lot of them. And so all of a sudden, working on that muscle is one of the reasons we're doing this for our patients. And all of a sudden, if we lose a whole lot of weight, they're actually looking good BMI-wise. They're looking good on the scale. But once again, the quality of that weight isn't there. And so if we have a diminutive diet, and that diminutive diet is all of a sudden cut in a fraction because we're doing GLP-1, or we have now a very small stomach through bariatric surgery, this is where Dr. Kumar, endocrinologist, so a hormone doctor in New York City, says sarcopenia affects the elderly population. Yes, that's true. And typically is associated with aging. However, rapidly losing weight with GLP-1s without proper diet and exercise can cause sarcopenia, sometimes referred to as the skinny fat. So even conventionally trained medical providers are saying, this is not good. This will negatively affect their quality of life, reducing their stamina, performance, and so forth. And it only makes sense clinically that, well, great, now I'm eating less of the food I was already eating, which led me to my weight issues. And I was like, okay. So we need to make sure we're augmenting their diets with vitamins, minerals, nutrients, because the micro and macronutrient deficiencies are going to be very pronounced. And you'll see on one of the slides all the nutrients necessary for phase 1, phase 2, and phase 3 detox. So let's say we all successfully get to our perfect BMI. We no longer have any issues. We're not sarcopenic, but now this heavier person, and let's see the little shadow person, is a thinner person. So now with my thinner patients in my clinical practice, I'll either have them wear a weight vest or something, because when they're exercising, they are doing less weight-bearing exercise. So you see this group of friends up there, and all of a sudden they all become optimal BMI, whatever that is for them, their body frames and their goals in life. But now they're all thinner. Do they have to do more exercise or more impact, more resistance training to help with weight bearing than when they were heavier? I'll let you determine that. So once again, a vicious cycle. And that vicious cycle of the more muscle loss we have, the more sedentary we are, the more likely we are to get injured. Then we end up with higher myostatin levels, because when we get injured, myostatin levels rise. And once again, with skinny fat, that's a form of obesity, and that will also increase myostatin levels. And Fortetropin addresses that. As you can see, the two little arrows here pointing to sarcopenia and what happens. And that's a natural aging process. And I'm going to vilify myostatin pretty heavily, but you're going to see that myostatin is a yin-yang balance, a teeter-totter, a tick-tock, so to speak. But sarcopenia and Alzheimer's go hand in hand. They impact, once again, neuroinflammation. And with neuroinflammation, by the way, we're more anxious and we're more depressed, all things being equal. So healthier muscle, generally lower inflammatory aspects, unless you're doing your personal best PRs and you've just torn yourself up doing CrossFit or something. But I mean, generally, it helps control and create positive cytokines that control. But as our mind goes, we know the gut-brain connection. Well, the muscle-brain connection is invariably important. And so when we look here at the concept of reducing myostatin, remember, myostatin is higher with aging. Myostatin is higher with disuse. Myostatin is higher with obesity. But when we reduce myostatin, we increase a substance called irisin. You're very familiar with it. It promotes metabolic effects. And you can see irisin here, and it helps with bone health. So all of a sudden, we're reducing myostatin. Could this be part of a protocol for your osteoporosis patients? Yes. Could this be part of it for the rehabilitation patients? Yes. And myostatin inhibits muscle growth. So what we're trying to do is, when myostatin levels are rising with aging, with obesity, with disuse, sedentary lifestyle, we want to lower the myostatin so it's no longer inhibiting the muscle growth. So very, very important. And they did a study of mice. They, of course, do lots of studies with mice and animals and all kinds of things. And they made them so that they did not have the myostatin. So they took away myostatin. And this is what happens. If you have no myostatin, you become muscle bound. And you can see the bull over there. Not a healthy circumstance where you can't even button your shirt if you're the bull, so to speak. But once again, we want to lower myostatin to increase irisin, which has all these health benefits, including decreasing inflammatory action, helping with glucose regulation. So we want to be Goldilocks, the just right zone. And unfortunately, with aging and the sedentariness and disuse, we're not in the sweet zone. And we see here the graphic of myostatin and irisin, and you can see I have the title Trigger Alert. And you say, oh, that's not very complex, Dr. Meletis. But once again, you're seeing here bone marrow, you see osteoblasts, which are builders, osteoclasts tear down. So once again, the myostatin is a thing that we want to lower. But then we get to the real trigger alert, the complexity of the human body. And when we're working with our patients with exercise and so forth, we're hopefully going to see an increase in mTOR, hopefully increase in IGF-1. Within reason, we want to see increased protein synthesis. But this is the yin-yang balance between sarcopenia over here, obesity over there, and the conflict that's occurring. And for the male patients you have that are heavier, let's say they're my age, right, they're circa 60, they might have actually more estrogen than their same age female counterparts, because we convert our testosterone through aromatase, into estrogen, and welcome to male breast tissue. So when we see the concept of helping our patients, we want to help with thermogenesis. And it all comes down to mitochondria. I lecture on mitochondria. I've written on the mitochondria quite a bit. And we know thermogenesis. If I go outside and it's cold, which I did last night, so I was sharing with Marianne, we lost our gas water heater last night, and we're up till midnight with the natural gas company turning off our gas so we don't implode and explode. But now all of a sudden I'm in my shorts, I'm in my dress attire of summer and indoor living. And all of a sudden it's cold and I'm start shivering. That's thermogenesis. That's also called the cold plunge, by the way, where we're triggering mitochondria, all that rage. But we want to trigger our white fat cells by cold exposure. Certain hormones like irisin, once again, lower the myostatin. Irisin will improve norepinephrine, of course, which is related to adrenaline and resistance training. And we want to support that thermogenesis, but we want those brown fat cells to start working and promote the weight loss. And so vitally important. And so once again, it all comes back to the mitochondria in large part. And here's a 2023 peer-reviewed journal article showing the effects of white fat cells and brown beige fat cells and energy storage. You can see in white blood cells. But then we see over here, we go brown, we got thermogenesis. You can see, I love this one, the cold exposure. Welcome to the cold shower, which is something I got to experience today with no hot water heater. High UCP1 expression and thermogenic effect within the mitochondria. So we want to support the mitochondria with CoQ10 and nicotinamide riboside to support NAD, maybe some bioperin, maybe some PQQ, pyroquinone, quinone, onwards and onwards, because we're trying to support this process. And once again, MYOS MD is part of a modular system. So whatever you're currently doing with your clients, diet and lifestyle-wise, this just ties right into it. So we can see adipose browning, which is what we want. We want cold exposure, we want the health promoting whole foods diet, exercise, and there are some pharmacotherapies out there as well. But you can see the outcomes, what we're looking for. And when you see more thermogenesis, more biogenesis, that is more mitochondrial density and number, this is a good thing. Remembering we're losing 10% of our mitochondrial function from the age of 30 onwards, all things being equal. So I'm right there at 60. So I'm 30% lower in my mitochondrial function than a 30-year-old. So the playing field's not level. So I do a lot of mitochondrial support on a daily basis to try to level that playing field. So we're all familiar with the mitochondria. That's their little Energizer bunny batteries. And here they have in red obesity. And then we have exercise, our bread and butter. So we look here at the inner membrane of the mitochondria, and we have the electron transport chain. But look at here, with obesity, we have decreased beta oxidation, decreased citric acid Krebs cycle. We have increased reactive oxygen species. That's the internal rust of our body that causes damage. We have a decrease in step 4, and we have a decrease of ATP when we're obese. But if we're obese and we're trying to carry our lumbering body around and we have less energy to do it, it just further feeds into the fatigue. And also we see more mitochondrial DNA mutation, and that's not good. Whereas you can see exercise has exactly the opposite effect. It validates what we do. And so when we look at the human cell, we're looking really at the equivalent of my cell phone. And this is an analogy I give for my patients. My cell phone has all kinds of wonderful apps on them. But if my apps don't have a charge to them, what happens? I have a glorified paperweight. So likewise, our human cells, our brain, our lung, our skin tissues, whatever, we're healing from a joint injury. Well, we have to have the energy for the DNA, which are like our apps, to actually manifest their prime directive. And so I do a lot of citric acid testing, organic acid testing. You can see proteins, carbs, and of course over here will be fats. And you can quantify that. So if you're into the really scientific analogies and looking for the data sets, but you can see wherever there is a star here, it happens to be a place where you need more NAD, which also diminishes. They say by the age of 40, our skin alone has 50% of the NAD it used to have when we were younger. And it is required for 500 enzymatic pathways, NAD alone. So let's move on to the topic of the day. Yes, it took that long to get to it, but we're really looking at a functional medicine wellness conversation about how things all work in concert and addressing the cause, or we say in Latin, total causum. Fortetropin, it's an all-natural bioactive compound derived from raw fertile eggs. What do we get in the grocery store? Non-fertile eggs. What are we told to do? Cook them. Totally messes up the benefits of the eggs. And so this actually has been shown in the peer-reviewed literature to enhance muscle protein synthesis rate, decrease that myostatin, and increase muscle growth. So let's go into some of those studies as we chat here. So myostatin is important for a therapeutic target. It's involved in several disorders, including diabetes and obesity. So higher myostatin, higher risk of diabetes and obesity, all things being equal. And if we control the myostatin and neutralize them, and there's some drugs they're trying to develop, and we have a whole food here and the Fortetropin, it improves muscle homeostasis and metabolic disease. Myostatin works as a negative regulator. So the higher the myostatin, the less muscle growth we have. So Fortetropin helps lower those myostatin levels. And if we decrease the myostatin, it improves insulin sensitivity and reduces obesity. So once again, helping our patients, they lose weight, and we're all familiar, probably most of us as well, probably the yo-yo diet. Now we're trying to leave them to the point where you've done the work, you've lost the weight, hopefully you support your detox pathways, and now let's load on that lean body mass so that we can maintain a new you for the rest of the life, opposed to that very dangerous yo-yo. So the peer-reviewed literature on Fortetropin, and we're going to go over each one of these, but I'm just going to show you they exist out there. Journal of Gerontology, 2021. We actually have the effects of Fortetropin on body composition, strength, and power in humans. They also did a parallel with rodents. And then we also look at Fortetropin supplementation and circulating myostatin and disuse syndrome and atrophy. And then we also see Fortetropin inhibits disuse in dogs. I kind of love it when they do an animal study, let alone I love my fur babies. But it's like, okay, well, the dogs really don't know. Here's where your chow, eat it. But they have zero expectation. And so, but the dog study was on the equivalent of a knee replacement, which we'll show you. And it's like, wow, the dogs that did not get the Fortetropin lost girth in their muscles of their leg, whereas those that took Fortetropin did not atrophy. Very compelling. And so myostatin reduces protein synthesis. And so that's why we're trying to lower it. It rises with age and disuse and obesity and diabetes, onwards and onwards. And we're trying to break that cycle. Very interesting. Some of our patients, which I've been desperately working with for the last 33 years, are the frail patients, whether they're female or male, that are out there and they're afraid to go out because it's cold, it's wet, it's slippery. They don't want to fall, but the highest in physical, frail, older women, the higher the myostatin. So we want to lower that myostatin level. And so what they found in the journal, they said, and I quote, myostatin inhibition, once again, Fortetropin, provides a promising means to attenuate or reverse skeletal muscle loss in the context of sarcopenia, as well as cachexia, diseases associated with muscle loss, to enhance skeletal muscle regeneration in the context of congenital diseases, including muscular dystrophy and injuries, which I'll share a case about that as well. In a human study of trained athletes, 37 of them, resistance trained athletes, lean body mass significantly improved when they were given Fortetropin compared to placebo. And so what they were given was either 19.8 grams or 6.6 grams. Both had improvements, and their lean body mass, just by going ahead and supplementing. Now, there was better improvement with a higher dose. And so both had improvements, significant increase in muscle thickness. Fortetropin also decreased markers of protein breakdown. So once again, our patients are putting their time in. Let's give them the rewards and have them have some additional dividends. So then the Berkeley site, one of the professors, Dr. Evans, which goes around the country lecturing on sarcopenia. This was a 21-day study in older adults. They did not change their exercise. They did not change their diet, except they either took Fortetropin and they saw, well, what happens? And so it's a randomized, placebo-controlled, double-blind study, 20 participants, and once again, not changing anything else in their life. Within 21 days, they had 18% higher levels of protein synthesis. Like, wow, wouldn't we all like that advantage with, once again, a whole food product? So the study indicated Fortetropin has the potential for managing age-related muscle loss in sarcopenia in older adults. And I quote here, the lead researcher, stimulating muscle protein synthesis in elderly patients could potentially result in increased muscle mass and better outcomes for those in sarcopenia. And remember, as we're all getting older, and I remember when I was 30 and 35 and 40, I never thought about getting older, but it's like, wow, injuries happen, life happens, surgeries happen. Once again, the more muscular you are, the more fit you are, lower your morbidity, mortality. Still have to look both ways crossing the street, but overall, you're going to put the things in your favor. So here's the dog study. The dog study is compelling. So you can actually see the little dog picture, a little cartoon there. And then you can see a human patient, which I just picked a knee replacement equivalent. So in the study, suffering from disuse muscle atrophy, they actually had the equivalent of a knee replacement, and they were given Fortetropin. And those that were given Fortetropin had no change in their myostatin levels. However, what they had was they had also no change in their thigh circumference, whereas the placebo group atrophied. We've all seen people in a sling or a walker boot, and then their muscle on one side and their leg or arm is dramatically different. So very compelling studies. And so the goal here is that we want to decrease myostatin. And so Fortetropin does that. There are some drugs, some antibodies, some peptides they're playing around with. Of course, resistance training has been shown to reduce myostatin. So we're already doing that work with our patients and making sure we have leucine. We're familiar with isoleucine, of course, valine, but leucine in particular, as a branch chain, is very critical for elevating the effects of protein synthesis. So very, very important. Then we see young-aged, physically active individuals. Then we sedentary, and what happens? Sarcopenia, decreased muscle mass, decreased number of mitochondria. So I always do mitochondrial support with my patients, especially with the aging process, and impaired biogenesis. So not only do the skeletal muscles have a lot of mitochondria, and once again, thermogenesis and shivering, also think about your heart. It has up to 500 mitochondria per cardiomyocyte. It's like, wow. So once again, support our mitochondria, vitally important. We all know that. But now we go to age-related hormonal changes, because we can control the myostatin. We can make sure they have enough vitamin D. We can do all this, but certain hormonal changes occur. So I wanted to capture that, because one of the beauties when I go to presentations is seeing a snapshot of everything I think I know, but also having it all in one place. So it's a nice little refresher. So measuring cortisol levels. Cortisol, of course, is catabolic. Testosterone, anabolic in female and male alike. DHEA, anabolic. Testosterone, anabolic. Cortisol, stress hormone, catabolic, tears you down. And so it's like, wow, okay, so we have these hormone changes. We see the changes in the muscle. And I saw this picture. I purchased this picture for this presentation. I'm saying, good for this fellow. He gets to be sitting at home playing with his cat or dog or grandkids or retired, but he is keeping his body in motion. The body in motion stays in motion. Skeletal muscle insensitivity to normal stimulatory effects of dietary amino acids is what anabolic resistance is. So once again, we can have the same amino acids as a young person, same amino acids as an older person or a person with sarcopenia, which can also be a skinny young person, and then anabolic resistance occurs. So once again, with controlling the myostatin levels and doing the exercise at the same time, we're going to help lessen anabolic resistance. So the diet will actually work better for them. And we see muscle as an endocrine organ. So we think pancreas, endocrine, makes insulin. Thyroid makes thyroid hormone. Gonads makes estrogen and progesterone, testosterone. Adrenals, cortisol, cortisone, aldosterone, and of course, epi, norepi. So we know all these things, but the muscle communicates with all these tissues, our brain, our liver, our gut. And so once again, we often in our training in a westernized mindset is like, okay, I go to a cardiologist, I go to an endocrinologist, I go to a surgeon for orthopedic surgery, or I go to a GI doc. But you really think about it, we're really, when we're training and treating the muscle, we're helping all those parts. So hopefully we visit a specialist less often. Because otherwise, when we have sarcopenia, we get a domino effect. And our goal, we're the hand. We're saying, no, we're going to help support the muscle so we don't have that domino effect riddle away the well-being of our patients. So this is interesting. You've seen a lot of 2023, 2024, 2020 articles. Here's two 1953 articles. Why in the world? Well, in London, in 1953, they did a study. And they looked at drivers of the trolleys. So welcome to the world of being sedentary. You sit while you drive. And they had twice as many heart coronary events than the conductors. Conductors were walking for a living. They were not stationary. They had to collect the tickets. So once again, that concept of body in motion stays in motion. And so when we look at the electron transport chain, oxidative phosphorylation, the sarcomere ATP consumption. And what are we looking at? One of the very popular things we've heard a lot about, whether we agree with it or not, the cold plunge. Of course, you better have a good cardiovascular system. But at least this fellow grounded himself with his bare feet on the dirt, terra firma, and it looks like he's having a great time. So once again, put our mitochondria muscle to work by stimulating with cold therapy. Am I proposing that for everybody? Of course not. But I thought it was a fun picture to share. And then we see the muscles and effect on the brain and sharpness. So you have anxious patients, depressed patients, patients with neurodegenerative problems. And so once again, we start seeing the effects at a hormonal level, anti-inflammatory, BDNF, interleukin-6, the IGF-1, and once again, all these inductions that we see with, once again, myokines. And the myokines were really discovered in 2000, so not that long ago, some 24 years ago, but they help with diabetes and neurological problems, cardiovascular problems, obesity. So once again, exerkines, welcome to the world of myokines. Myokines are a type of exerkine. And I like the term exerkine because, of course, it really explains the exercise side of things. So exerkines have the potential to treat and help treat cardiovascular disease, diabetes, obesity, and facilitate healthy aging. There's a biological age, as we know, and then there's a chronological age. Chronological age is when we get carded. Now I get carded for senior discounts, but I remember younger me got carded for, are you old enough to be here? And it's like, okay, but what's my biological age? So I want to be biologically younger than my chronological age, and exercise is paramount to that, and fitness. So a couple that stays in shape along the way will do better and have a younger biological age, all things being equal. Always a caveat, small print, right? So what happens is when we lose muscle mass because we have nerve damage, we lose muscle mass because of andropause, male menopause, and menopause, elevated cortisol levels, welcome to stress. And it was actually the Dalai Lama, which was asked, what surprised him most about humanity? And I will paraphrase him because I can't do justice to his quote, but it's mankind, humankind, because they'll trade their health to gain wealth and then trade all their wealth to regain the health, and all the while living an anxious, unfulfilled life. And then we have elevated inflammation. We have anabolic resistance. That's where we're not getting amino acids like leucine and other amino acids in to support protein synthesis. And so once again, myostatin levels drop with Fortetropin. Anabolic resistance drops. So these are things that will allow for better skeletal muscle function. Disuse syndrome, injuries, all these things cause atrophy. We have poor nutritional status, GI health, taken around to antibiotics, got food poison. Now your GI tract's not assimilating. As we get older, they say up to 50% of us by the age of 60 have little or no stomach acid. Now, if you take a proton pump inhibitor or H2 antagonist, so acid blocking pills, you're not going to break down your proteins as well. So you're probably not going to assimilate them, one would assume. Same thing with our minerals. And once again, rapid weight loss, whereas controlled starvation, which of course will cause problems. And we need to be, of course, proactive in our steps and taking our well-being very seriously. So I'm going to finish up with these cases. I have a 63-year-old. She has severe osteoporosis. And sadly enough, this patient I've known since 1992, when I graduated, fell off a ladder. She broke things because she has severe osteoporosis. She's very petite. She doesn't bear a lot of weight. And that injury and being put back together with screws and plates, and she's underweight. So I have her on Fortetropin because it's part of her osteoporosis protocol. And then we see over here that we have pre and post-surgical knee replacement. So I have a 55-year-old. He has 5 young boys, 18 down to 11, and he plays soccer with his kids. He's very athletic. He's very ethnic. And football, there's only one kind of football for him, and it's soccer. He has great BMI. Everything's great. But he's now suffering from a disuse syndrome because he had knee surgery, and I'm trying to prevent that from. So pre-surgically and post-surgically, I'm using Fortetropin. And then here we have an 86-year-old, phenomenal story. I've known them since 1994, and it's a husband and wife. He was a physicist. She was a chemist. She broke a glass ceiling before we even knew it was a glass ceiling. And they both do about 10,000 steps a day. At least they used to. But he broke his femur. Ended up in a nursing care facility because she couldn't take care of him for a while. Now he's back at home, but he's having to rehabilitate himself. So luckily he had those 10,000 step history, but we have him on Fortetropin because he's finding it very hard to maintain the muscle control and the muscle density to walk a straight line without risking falling, which of course he's afraid to do again. So we have him on Fortetropin. I had a 35-year-old healthcare provider. He lost 40 pounds. I did not prescribe the GLP-1. And lo and behold, I said also check for sleep apnea, obstructive sleep apnea, OSA. But he gained all his weight back once he stopped GLP-1. Now, of course, we have him on Fortetropin because he's looking on supporting his weight. He plays basketball with his friends, but we're controlling his sleep apnea because once again, we can live a long time without food, a few days without water, but only moments without air. He was very severely apneic. And this one's sad case, a young boy, a patient of mine in Florida, Jacksonville, Florida. He has Duchenne's muscular dystrophy. He's wheelchair bound, but he actually had to have help going potty, showering, everything else. We put him on Myostatin in small print here. Individual results will vary, but now he's actually much more mobile. He's still in a wheelchair because of the nature of the disease, but now he can potty and shower and have some quality of life. And so Fortetropin mitigates anabolic resistance by inhibiting myostatin and supports healthy levels of mTOR. Consume sufficient calories. We have to do that while we're doing a program here, a little summary. Otherwise, our T3 will convert to reverse T3, which is the hibernation mode. And then we have sufficient protein and essential amino acids, very important. Mitochondrial support, NAD support. I like nicotinamide riboside, CoQ10, PQQ, and resveratrol, along with others. Exercise, of course, that's your expertise, more so than mine. Detoxification support, absolutely critical. We're mobilizing yesterday and yesteryear's fats and toxins, and even transplacental toxins you got from mom while you were on board. Well documented in the peer-reviewed literature. So this is a little graphic I've created. I can offer it in a larger form for you for educational purposes. We have a toxic fat-soluble substance. We go through a phase 1, and we make it a hot potato where it's more highly reactive. Then we have to go through phase 2, grab it, process it quickly, and then pee and poo or sweat it out. But you can see all the nutrients necessary. But imagine, unless you're taking a really phenomenal amino acid, protein, and something like Fortetropin, you're not supporting phase 1 and phase 2 while you're losing your weight. So how are you going to get rid of those toxins in an efficacious fashion? You're not. And so, of course, we got to make sure there's good sleep. And of course, I do an array of tests. This is just a smattering. I'm known at the local Quest diagnostics draw station as trying to kill my patients all the time as they take 25 to 30 tubes of blood. That was in jest, but they were like, wow, we know you're one of Dr. Meletis' patients. Yeah, we go deep because we want to know what's going on. We need data sets. So I'm going to open up for questions, but our talk today was on Fortetropin. There's a vanilla flavored. There's a standard one. I have the standard one right next to me here. It doesn't taste like anything. If you like French toast, it's wonderful. It's been shown to increase muscle growth, enhance muscle protein synthesis, and lower circulating myostatin, and help with the anabolic resistance. And my contact for me getting it for my clinic is Greg Arabatis. Here's his telephone number, or you can email him. So I'm open for questions.
Awesome. Thank you so much. Well, if anybody has any questions, actually, Doug has jumped right in with a question. He said,
awesome.
How long is the treatment plan?
So it depends. If we have a disuse syndrome, we're doing it before, after, and during rehabilitation at the very least. If a person is doing the GLP-1 protocol, we'll do it during the protocol, and then afterwards, depending on how on top of it they were with their diet and their lifestyle. If we have a person that's coming in maybe in my shape, it's going to be a little longer because I'm deeper in the hole because I've been a very good sedentary worker. And that's why the Dalai Lama quote I share, not because I'm a big follower of the Dalai Lama, but I think he is inspired because I've traded my health to gain notoriety, and now I'm having to regain it. So it's going to take me longer because I'm in a deeper hole. So I would say for the disuse, before surgery, after surgery, and until they've rehabilitated to their previous state or better than their previous state. For the GLP-1s or the bariatric surgery, particularly the bariatric surgery, but also the GLP-1s, pretty long-term. I mean, but we saw in the study 21 days alone with elderly, so older individuals. So they saw within 21 days an 18% in protein synthesis. So you can make it as short as long, and that's the beauty of what you all do. You're the one that helps determine when they've hit their threshold.
Interesting. So a follow-up from Doug. So if he's a client who was told that they would be on the GLP-1 for the rest of their lives, would they have to use this for the same length of time?
So of course, GLP-1 is an off-label use for, of course, diabetes. And of course, diabetes is also known as type 3 diabetes, which is Alzheimer's disease. And there's a correlation there. And we see a lot of our diabetics, unless they're being very carefully guided by individuals like are on the call, that they do end up with muscle wasting and memory problems and so forth and so on. So for those individuals, it's about getting them to a good stable spot and then tracking them over the course of time. So if they're using it, like I have a friend, which is actually related to the couple that had their bariatric surgery, and he's fading tremendously from a memory perspective, God bless him, but he's out of control with his diabetes. His diabetes blood sugars are too low, and so therefore his cells aren't being functioned, and he's on a GLP-1, and the polypharmacy is getting him a little bit. I think he's on a little too many meds, and so whenever we see him, often I have to give him some of my wife's glucose pills to save him, as he's a 67 blood sugar. So it depends on meeting the patient where they're at. So we always treat the patient, not the lab or the drug. But if a person's on a weight loss GLP, definitely during that entirety. For a long-term one, you kind of figure out their budget and also how their overall health is. So just common sense.
Okay. Well, great. And if again, if anybody has any more questions, oh, Lisa does. So Lisa is saying she had her thyroid removed due to thyroid cancer 12 years ago. Would it be more difficult to regulate proper Fortetropin levels as her thyroid levels fluctuate?
No, not at all. All of us deal with thyroid patients, those that know they have it and those that don't. There was a study done in the late 90s, early 2000s. They did a survey out of Colorado State Fair, and the people that were on thyroid medicine were actually a very large percent were not properly dosed. And then a lot of people were being tested randomly and they didn't even know they had thyroid problems. So as long as the T4, T3, free T4, which is like free hands, and free T3, free hands. And remember, free T3 is more active. Lots of providers don't measure free T3. Very, very important. So if TSH is good, but usually between 1 and 2, and free T4 and free T3 are mid-range, should not be a problem. If there's a thyroid issue and they don't have enough free T3, yeah, then it's going to be harder for sure. It's a brilliant question, actually.
Awesome. So Doug has asked again, are there any adverse effects or interactions of using this in addition to whey protein and or creatine?
No, in fact, it works well with whey protein. It works great with creatine. But the one contraindication for this is if you're allergic to eggs, this is not your product. It looks like egg except because it's egg yolk. So that would be the one big thing. Or for some reason your doctor says you have to totally avoid all cholesterol. And yeah, we know a vegetarian vegan will make cholesterol every day of their lives in their liver because it's critical for our existence. And there's a lot of controversy. I'm not going to step into that one, but does even dietary cholesterol really impact our overall cholesterol? And for those that aren't familiar with the Cleveland Clinic or the Boston Heart Lab, there's a lot more measures than just cholesterol that we need to worry about. You need to worry about apolipoprotein A, lipoprotein B, CRP, homocysteine, myeloperoxidase, another whole nother lecture I give and things I do in my clinical practice. So I do for my patients a Quest Diagnostics Cardio IQ Advanced because I don't want to just look at HDL and LDL. I want to know the size of their LDL. Because if we think of an apple and we think of a blueberry and we drop both of them in a refrigerator, in front of the refrigerator, which one's going to get stuck in a nook and cranny? The blueberry. Well, likewise, LDL B pattern, which is the small blueberry type, are much more likely to get stuck than the A pattern. And we want to all be A pattern LDLs, but 90% of us on the call don't know that we're an A or a B pattern. All we know is our LDL level. So there's just so much data out there that once in Cleveland Clinic, Boston Heart Lab, doing these studies, and I do it all my patients, everybody gets an executive cardiovascular panel from me. So I don't worry about cholesterol as much. Of course, we have to control it, but it's from a dietary perspective, it's just part of the bigger equation.
Awesome. Okay,
Great questions.
Yeah, if anybody has any more questions, again, you can put them in the chat, you can put them in the Q&A panel. We'll see them both. As we're waiting for more questions to come through, I'll just say thank you to Dr. Meletis for sharing your knowledge with us today. And all attendees will receive an email after this webinar with an evaluation link for the webinar, and it includes a spot to indicate which CEC you'd like to receive. So be sure to complete the survey. But even if you're not looking for a CEC, your feedback helps us in planning educational webinars and helps our speakers with their presentation skills. Not that that's an issue here, mind you. Lisa said, a family member isn't allergic, but eating eggs causes intestinal issues. Would it cause the same issue here?
It may. So there's food allergies, which is the conventional allopathic MD world of a person's allergic. Then there's food sensitivities. But now the challenge with this is, since this is a fertilized egg yolk, there's no egg white in it, it's maybe better tolerated, but only a clinical trial will tell. And I ended up giving this product to my wife. So I only recommend products or educate on products I use for myself, my family, and my patients. So my wife doesn't like eggs. She doesn't mind this, but I mooch off her all the time. So what's great is many family members can benefit from a canister. So.
Awesome. And do you happen to know the cost of this supplement? Kenneth
I do not.
Okay.
And my office manager, you would think I would, but I leave the higher, harder things to my administrative help. And my office manager and friend for the last 15 years does all the hard, heavy lifting. I'm just, the pretty face.
Okay, so Kenneth, you'll have to check online.
Greg is a great resource. Code. Greg is a great resource. Just reach out to Greg. He's very personable. He's on the East Coast. He's a New Jersey fellow. And so Greg can provide all of that and also all the literature. And I'm going to send to you, Mary Ann, this presentation so people can have it for their archive.
Yes, I would. And I will definitely send it out to everyone. And how frequently do you take this?
You take it on a daily basis. You take one scoop. One scoop is in the middle of that one clinical trial for the resistance trained athletes, which I use either 16.6 or 19.8. One scoop is 13.2, I think, grams. So I just use one scoop. If we're really playing catch up, you can do more. Like in the case of my Duchenne's muscular dystrophy patient, he's doing 3 scoops a day. He's 13 years old, but we're fighting a huge fight for him. You know, we're fighting for his life.
Yeah. Now, is this something that you could mix into other ingredients in a smoothie?
Oh yeah, a smoothie. Lots of people will put it in their Greek yogurt. You name it. My wife doesn't like yogurt. She doesn't care for like a scrambled egg. I make scrambled eggs every morning for myself. But she actually puts it in seltzer water. Yeah, so you can mix it in whatever you want.
Oh, okay. That's easy enough. Okay, so while we're waiting for more questions to come through, I will say that our next webinar is actually this Thursday, December 12th, and it's entitled The Role of New Technology in Strength Training. And this is actually a promotional webinar with Technogem. The presenter is Dr. Silvano Sanuso. He's a scientific research and communications director at Technogem. And then our final webinar for 2024 will be next Wednesday, December 18th. And that one's entitled Fitness Refresh, Seize the Opportunity with Kelly Spivey. And this one is going to look at ideas for your gym layout to create a great member experience. So you can visit the education tab on the MFA website at medicalfitness.org, and you'll see the links there to register. I just want to say thank you so much to our sponsor, MYOS MD. You can learn more on their website at myosmd.com. That's MYOSMD.com. And like I said, I will send out the slide deck so you have all of this great information, including the promo code that's right in front of us that you can use on myosmd.com. That's on the last slide. Natalie is saying, thank you so much.
Well, thank you. And thank you, Doug. Thank you, Natalie. Thank you, everyone. And I applaud you all. I mean, you're actually the bread and butter of wellness, and we often forget how important fitness is. And you're making probably some of the biggest changes in people's lives. So, and even though it says muscle formula, this is something I use with my osteoporosis patients all the time as well.
Oh, really? So this is, Now
Yeah,
you piqued my interest too.
yeah. It's just
Oh,
it's a beautiful.
interesting.
And if people have questions, they can contact Greg, and then I'll be more than glad to chat with people. I just love chatting with colleagues around the country.
That's awesome. I really appreciate that. Um, awesome. I'm not seeing any more questions, so I will thank everybody for joining us today. Thank you so much to Dr. Meletis for sharing your knowledge with us, and enjoy the rest of your day, everyone.
Thank you. Take care. Be well.